Hello and welcome to the Irish Hematology Oncology podcast. Again, this podcast, we aim for it to be like grabbing a coffee with a trusted colleague to discuss the latest in cancer care, break down complex topics and share practical experiences. I'm your host, Eoin Tabb. And today I want to give you a very, very crashy course on cancer staging, especially fellow healthcare professionals who want to learn more about how we approach cancer treatment. So let's dig deeper into this concept of cancer staging. Imagine this scenario. A patient comes to their doctor with a concerning symptom, let's say a persistent cough. After some tests, the doctor discovers a tumor in the patient's lung. That's the starting point for cancer staging. Staging is like creating a detailed map of the cancer's territory. It answers crucial questions that can help guide treatment decisions. So firstly, how big is the tumor? Is it a small localized growth or has it grown significantly? Has it spread to nearby lymph nodes? Lymph nodes are like little checkpoints in our immune system. If cancer cells lodge in the lymph nodes, it's a red flag that it might be spreading further. Has it spread to distant organs? This is called metastasis. And it means that cancer is no longer confined to its original location. The whole purpose of cancer staging is to help doctors decide the most appropriate course of action. Think about it like battle planning. A general wouldn't send the same size army to fight a small skirmish as they would to conquer a vast territory. Similarly, the treatment for an early stage localized cancer will differ significantly from the treatment for a late stage cancer that has spread throughout the body. So now that we know what cancer staging is, let's get into the nuts and bolts of how it's actually done. As healthcare professionals, it's useful to be familiar with different tests and procedures that might be involved in staging a patient's cancer. Remember, staging can happen at a few different points in the patient's journey. So clinical staging, this happens before any treatment begins. It's based on the results of the initial physical exam, any imaging scans done at the time of diagnosis, and biopsies. Clinical staging is an estimate of the cancer's extent and it helps guide initial choices. Then you have pathological staging. This type of staging is more precise. It happens if the patient undergoes surgery to remove the tumor. The pathologist examines the tumor, surrounding tissue, and any removed lymph nodes under the microscope. This gives a detailed picture of the cancer's size, how deeply it has invaded tissues, and whether there is definitely spread to lymph nodes. This information might lead to adjustments in the treatment plan. And then you have restaging. Sometimes doctors will restage a patient's cancer after a course of treatment to see how well the cancer has responded. This helps determine if the current treatment is working or if a different approach is needed. So let's delve into specific tests used for staging. So you have imaging tests. Imaging tests are the workhorses of cancer staging. They create pictures of the inside of the body, giving doctors a non-invasive way to visualize the tumor and surrounding areas. Here's a quick rundown of some common ones. So X-rays. This is often one of the first line imaging tests. While they're best for looking at dense structures like bones, X-rays can sometimes pick up tumors in areas like the lungs or breast tissue. Then you have CT scans or computed tomography. CT scans are like taking multiple super detailed X-rays from different angles and piecing them together with a computer. This gives us cross-sectional images of the body, allowing for precise visualization of the tumor's size and function. CT scans are super helpful for looking at lymph nodes and checking for spread to other organs. Then you have MRI scans or magnetic resonance imaging. MRI scans use powerful magnets and radio waves to create detailed images, particularly of soft tissues. This can be helpful for staging cancers in the brain, spinal cord, or for looking at certain soft tissue tumors in greater detail. And then you have PET scans or positron emission tomography. PET scans are a bit special. They use a slightly radioactive tracer that's injected into the patient. The cancer cells gobble up this tracer more than normal cells, making them light up on the scan. PET scans are great for finding distant metastases or determining if cancer has returned after treatment. Then we have biopsies. So while imaging is crucial, it's the biopsy that gives us definitive proof that we're dealing with cancer. Here are a few common biopsy techniques. You have needle biopsies. So doctors use a thin needle to remove a small sample of cells or tissue. This can be done either with the guidance of an imaging test like an ultrasound or a CT, or as a direct biopsy if the tumor can be felt during a physical exam. Then you have core needle biopsy. This is similar to the regular needle biopsy, but a slightly wider needle is used to collect a larger sample of tissue. And then surgical biopsy. Sometimes surgery is needed to remove either a portion of the tumor, which is an incisional biopsy, or the entire tumor along with some healthy tissue, an excisional biopsy. Pathologists then examine these biopsy tissues under the microscope. They tell us the type of cancer, how aggressive it looks, and whether it contains certain molecular markers that might guide targeted therapy options. And then you have blood tests. While blood tests alone won't determine stage, they provide valid information. So a complete or a full blood count, an FBC. An FBC gives a snapshot of the different types of cells in a patient's blood. Abnormalities in white blood cells, red blood cells, or platelets can sometimes be clues to certain cancers. Then you have tumor markers. These are substances found in the blood that can be elevated with certain cancers. For example, CA125 is a tumor marker often associated with ovarian cancer, and PSA is a marker that's often associated with prostate cancer. They're not perfect and can be elevated in non-cancerous conditions too, but they provide another piece of the puzzle. And other blood tests. So doctors may order checks of liver and kidney function to assess how well those organs are working and whether it has spread there. This is especially important before starting certain cancer treatments that can affect these organs as well. So earlier we introduced the concept of the TNM staging system. Now let's dive deeper into each letter and understand how those stages are actually assigned. Remember, TNM is a tool to categorize different cancers. The way it's applied will vary slightly depending on the specific type of cancer, but the overall principles remain the same. So T is for tumor. The T category tells us about the main tumor, also called the primary tumor, specifically related to the size and invasion. So T0, this means that there's no evidence of a primary tumor. Sometimes this is used when an early cancer was completely removed. Then you have TIS. This is a special term called carcinoma in situ. It means the cancer cells are still confined to the very top layer cells where they started and haven't invaded deeper tissues. It's a very early stage of cancer. Then you have T1, T2, T3, T4. These numbers tell us about the size of the tumor and how deeply it's invaded. A larger tumor or one that's invaded deeply into nearby tissues gets a higher T number. So let's use an analogy to make this easier. Imagine a tree taking root in your back garden. A T would be that first sprout pushing through the soil, relatively small and contained. A T4 would be a full-grown tree, roots extending deep and maybe even starting to crack the foundation of your house. Please note that the exact size ranges and descriptions of invasiveness depend on the individual type of cancer. For example, a D2 designation might mean a tumor between 2 and 5 centimeters for one cancer type, but a smaller or larger measurement for another type of cancer. This is why knowing the specific type of cancer is so important when interpreting TNM stage. N is for nodes. The N category is about those checkpoints of the immune system, lymph nodes. Lymph nodes are tiny bean-shaped structures scattered throughout the body. They act as filters, trapping back viruses and unfortunately sometimes cancer cells. So again, the categorization N0, this means that no nearby lymph nodes contain cancer cells. N1, N2, N3, these categories tell us how many lymph nodes contain cancer and how widespread the involvement is. Higher numbers generally signify more extensive lymph node spread. So let's stick again with our tree analogy. Think of those lymph nodes as sheds that have been set up around your house. An N0 state means your sheds are empty, no sign of intruders yet. But an N2, for instance, might mean multiple sheds have been breached by tree roots, showing the spread is more significant. And now out of our TNM, we go on to M. M is for metastases. So M tells us about distant metastases. This is when cancer cells break away from the original tumor, travel through the bloodstream or lymphatic system to take root in other organs. So M0, this means there's no evidence of distant spread. The cancer is still localized to its original area and the nearby region. M1, sadly, this means the cancer is spread to distant parts of the body. Often the most common sites for metastases include the lungs, liver, bones, and brain. Think back to our tree. An M0 means that while the tree might be spreading around your garden, there are no sign of seeds blowing into the neighbour's garden yet. An M1 would mean that stray seeds have spread from the tree and not only travelled, but they've taken root in a distant neighbouring garden. So let's put it all together, stage grouping. So after getting the T, N, and M categories, doctors use all that information to assign an overall stage. This is usually written with Roman numerals. So stage 1, these are the earliest cancers. They're generally small, haven't spread to lymph nodes, and there's no sign of distant metastases. Stage 2 and 3, these stages usually tell us the cancer is locally more advanced. It might be a larger tumor, there could be spread to more lymph nodes, or it may have spread to a limited degree in the surrounding region. And stage 4, this stage indicates the cancer has spread to distant parts of the body. Let's be clear, it gets more complex than this. Some cancers have further subdivisions within those stages, adding letters like A or B. And the detailed criteria for what constitutes for stage 1 versus stage 2 varies greatly depending on the exact type of cancer. The key here is to understand the bigger picture of what TNM categories and stages are trying to tell us as we approach treatment. So why does the TNM system matter? You might be wondering why get so specific. Well, here's the deal, right? The decision-making part. The TNM stage is a powerful tool to help doctors decide which treatment options are most appropriate. An early stage cancer might be treated with surgery alone or surgery followed by radiation. A more advanced cancer usually needs a combination approach with surgery, chemotherapy, radiation, targeted therapies, or immunotherapies, sometimes all playing a role. Prognosis as well. While there's always individual variability, the stage gives us a general sense of prognosis. In most cases, the earlier the stage of diagnosis, the better the chances of cure or long-term control. And research as well. The TNM system lets us compare results between clinical trials across the world. When researchers study a new cancer treatment, they often enroll patients with specific stages of cancer. By using a common language, scientists can better analyze data and identify the most effective treatment strategies. So now, as healthcare professionals, you might be wondering why it's important for us to have a solid understanding of cancer staging. Well, medication selection is incredibly important. Cancer treatment is individualized, and the stage plays a major role in determining which medications are going to be on a patient's treatment plan. So let's break it down. Chemotherapy. Many chemotherapy regimens are designed for specific cancer stages. A patient with an early stage cancer might receive chemotherapy after surgery, which is called adjuvant chemotherapy, to reduce the risk of recurrence. On the other hand, a patient with advanced cancer might receive chemotherapy to try to shrink the tumor or slow its spread. The dosages and specific drug combinations can differ depending on these goals. Then you have targeted therapy. These are drugs that target molecules or pathways involved in cancer growth. Their use often depends on whether the patient's tumor has specific mutations or markers. Knowing the cancer stage lets us anticipate which targeted therapies might be an option, and that means checking for potential drug interactions or counseling patients about unique side effects. And then immunotherapy as well. This is cycling type of cancer treatment harnesses the power of the patient's own immune system. Similar to targeted therapies, the specific immunotherapy drugs a patient is eligible for often depends on their cancer type and stage. And then also managing side effects. So as healthcare professionals, we're on the front lines when it comes to managing treatment-related side effects. Unfortunately, many cancer medications can cause a range of unpleasant and often times severe symptoms. Understanding the patient's cancer stage helps us to be proactive. So we can anticipate issues. Certain chemotherapy regimens are associated with higher risks of specific side effects. For example, some drugs are more likely to cause nausea, vomiting, and diarrhea. Knowing a patient's stage and treatment plan lets us anticipate these problems and provide preemptive education and medications. And severity as well. Patients with advanced cancers often receive more aggressive treatment regimens. This can make side effects harder to manage. Understanding the reason behind the intensity helps us tailor our counseling and support patients appropriately. And following on for patient education and counselling, let's face it, a cancer diagnosis can be incredibly overwhelming. Patients are bombarded with complicated medication information, and we become trusted partners to help them understand it all. So it's important for us to understand this cancer staging because we can explain to them treatment options. Patients often want to know the why they're recommended a certain course of treatment. Understanding staging gives us the knowledge to explain their treatment options in a way that makes sense to them. And adherence as well. So cancer therapies can be lengthy, involving multiple medications and a whole lot of appointments. Motivating patients to stick to their treatment plan is crucial. Knowing their cancer stage helps us emphasize why consistent medication use is so important in the context of their individual diagnosis. And then for interdisciplinary collaboration and research as well, today's best cancer care involves a whole team of healthcare professionals working together. Those professionals then with staging knowledge can more effectively collaborate with doctors, nurses, pharmacists, and specialists. The whole team can talk together into one language. Well, that covers our deep dive into cancer staging. I did say I was going to give a crash course today on it. I hope I've made things a bit clearer, giving you a strong foundation for interpreting those T's, N's, M's, and stages. It's a complex topic, but understanding cancer staging truly empowers us as healthcare professionals to be even better members of our hematology and oncology care teams. So as always, thanks again for joining us on the Irish Hematology Oncology podcast today. If you found this episode helpful, please subscribe, leave a review, and tell your colleagues in your own hospital or anybody else in hospitals around. Your support helps us continue bringing this information to you. Thanks again to anybody who has filled out the feedback form. I am taking all of your feedback, and it's been great. And the topics that are coming up on the line, I've rearranged items on the podcast, the feedback you've already given so far. So please fill out that feedback form to give me an idea if this has been helpful, how I can improve, and any future episodes or topics that you'd like to hear. And don't forget that important CPD is as well. I've put an example of CPD for pharmacists for the IIOP submission in the show notes below. And as always, I'll end on this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. All right, see you guys next week.